Okay, let's dive right into this evidence-based breakdown of the RCOG Green-top Guideline 20b. We're talking about the management of breech presentation. Now, managing a breech birth, it's honestly one of the most heavily scrutinized areas in obstetrics. You've got this incredibly delicate balance between complex maternal and fetal risks. And since obstetrics is a field where split-second decisions absolutely rely on a deep understanding of clinical data, breech presentation really tests that knowledge to its absolute limit. So whether you're gearing up for your MRCOG exams or just looking to sharpen your daily clinical practice, this explainer is going to give you the exact evidence grades, the clinical rationales, and the structured recommendations you need to handle these challenging cases safely and confidently. Let's get into it.
We'll be moving right along the actual clinical pathway today. First, we'll hit counseling and mode options, then move on to assessing vaginal birth safety, run through the intrapartum management guidelines, discuss delivery techniques, and finally, tackle those highly examinable complex scenarios, preterm and twin pregnancies. Starting right off with Section 1, Counseling and Mode Options. Before we even debate delivery modes for a persistent breech at term, your very first step is a solid Grade A recommendation. Offer an external cephalic version, unless it's contraindicated, of course. But, say the ECV is unsuccessful or the patient declines it, well, that's when the crucial counseling about the actual mode of delivery officially begins.
Now, to put this into perspective, the baseline statistic you literally must share with your patient is 0.5. That means the risk of perinatal mortality is approximately 0.5 per 1,000 when you do a planned cesarean section after 39 weeks. And waiting until that 39-week mark is key. It minimizes neonatal respiratory morbidity while locking in that risk reduction, avoiding stillbirth, intrapartum complications, and the specific risks of a vaginal breech birth. Giving your patient this incredibly low absolute risk gives her a super clear, data-driven starting point for making her choice. But you have to compare that 0.5 to 2.0. The perinatal mortality risk jumps to about 2.0 per 1,000 with a planned vaginal breech birth. This is a grade C statistic, and you absolutely need to memorize it for your exams and your everyday practice. Now sure, 2.0 per 1,000 is still a low absolute risk, but it's demonstrably higher than a planned C-section, and it's higher than the 1.0 per 1,000 risk we see for a planned cephalic birth. Presenting these absolute and relative risks impartially, that's the real cornerstone of informed consent. You just want to make sure the patient fully understands that while vaginal breech birth is generally safe, the fetal risks are for sure marginally elevated.
However, we've got to look at the other side of the coin here, maternal health. That fetal benefit of a planned cesarean absolutely has to be balanced against Grade B evidence, which highlights some pretty high maternal complication rates if a vaginal plan fails. And honestly, fail it might. About 40% of women planning a vaginal breech birth will end up needing an emergency cesarean section. Usually that's because of a lack of descent or sudden fetal distress. And an emergency section carries the highest risk of maternal morbidity compared to planned procedures. Plus, we must counsel on the long-term stuff, especially the escalating threat of placenta accreta spectrum in future pregnancies after multiple surgical deliveries. It's a really complex risk-benefit discussion, weighing immediate fetal outcomes against both immediate and future maternal health.
Moving right along to Section 2, Assessing Vaginal Birth Safety. So let's say a patient opts for a planned vaginal breech birth after all that thorough counseling. Our next job is to formally assess exactly when that plan becomes unacceptably high risk. And this brings us to a crucial Grade C visual checklist of absolute contraindications. If literally any of these are present, planned vaginal birth is simply not recommended. First, you have to check for a hyperextended neck on ultrasound because that carries a severe risk of spinal cord injury during delivery. You also need to assess fetal weight super carefully. An estimated weight over 3.8 kilos risks head entrapment, while a fetus below the 10th centile is highly vulnerable to intrapartum hypoxia. On top of that, a Footling presentation, which has an exceptionally high risk of cord prolapse or any evidence of antenatal fetal compromise, absolutely mandate a cesarean section. Knowing the clinical why behind each of these contraindications doesn't just make them easier to recall for the MRCOG, it directly protects your patients on the ward.
But you know, safety isn't just about fetal metrics. It relies entirely on the team you have in the room. The presence of a skilled birth attendant is a Grade C absolute must. Because of the historical decline in vaginal breech deliveries over the last few decades, we're seeing a recognized system-wide loss of these specific skills in today's obstetrician workforce. So units with limited access to experienced personnel actually have to advise women against vaginal breech birth and offer an antenatal referral to a unit where skill levels are up to par. It's a stark reminder that human factors and system resources are just as critical as the clinical numbers we measure on a scan.
All right, let's head over to the labor ward for Section 3, Intrapartum Management Guidelines. Once a woman with an appropriately selected breech presentation is actually in labor, strict protocols take over to keep neonatal morbidity to an absolute minimum.
Here is your intrapartum step-by-step guide. Step 1. Grade D evidence strongly suggests continuous electronic fetal monitoring. Because breech presentations naturally have a higher risk of cord prolapse and compression, continuous EFM is vital to catch any early signs of compromise. Step 2. You absolutely must ensure adequate descent in a passive second stage. That means letting the breech descend all the way to the perineum naturally before any active maternal pushing starts. This prevents the cervix from clamping down on the aftercoming head. And finally, Step 3. Avoid routine induction and be incredibly cautious with augmentation. Actually, oxytocin should only be considered if contraction frequency drops specifically because of epidural analgesia. Any other delay in progress should immediately prompt you to consider an emergency cesarean.
Now getting to the actual delivery, Section 4, Delivery Techniques and Positions. The delivery itself leans heavily on continuous observation and, above all else, an overarching commitment to avoiding fetal trauma.
When it comes to maternal position during delivery, both the semi-recumbent and all fours positions are entirely acceptable. The choice really comes down to maternal preference and, crucially, the operator's experience. But there is a major caveat you need to counsel your patient on beforehand. If she chooses the all fours position, sudden recourse to the dorsal or semi-recumbent position might become necessary if you suddenly need to intervene and the attendant isn't specifically trained in upright maneuvers. Communication here is absolutely key so the mother isn't caught off guard if she needs to be repositioned in a split second.
Now, the absolute golden rule of the delivery itself is assistance without traction. You only intervene if there's a delay or clear evidence of poor fetal condition, and you must know your specific maneuvers inside out. You'll use Lovset's maneuver to release nuchal or extended arms. For the aftercoming head, you utilize the Morisos-Melly bite maneuver or apply forceps. And please, note this carefully for your exams, the Burns-Marshall technique is no longer advised. Why? Because it carries a significant risk of overextending the fetal neck. You must never hyperextend the neck. Also, you always want to grasp the fetus securely around the bony pelvic girdle, completely avoiding the soft tissues of the abdomen so you don't cause any internal organ injury.
Okay, so up to this point, we've been focusing entirely on the straightforward term singleton. But what happens when we deviate from that? How do these rules shift when we run into premature labor or multiple pregnancies? These scenarios are highly tested and demand a much more nuanced clinical approach. Which brings us to our final section, preterm and twin pregnancies. This is a highly examinable area where standard term rules require some really careful, individualized deviation. For a singleton preterm breech, the guideline is clear, though maybe a bit counterintuitive to some. Routine cesarean section in spontaneous preterm labor is a grade C, not recommended. This is especially true right at the threshold of viability, meaning between 22 and 25 plus 6 weeks. Rather than a blanket surgical rule, this situation demands highly individualized care. You've got to base your decision on the stage of labor, overall fetal well-being, and whether you actually have a skilled operator available. Doing a routine section just because it's preterm is not the answer. Now, if delivery is being planned proactively because of maternal or fetal compromise, then yes, a planned cesarean is indeed the recommended route.
And that brings us to a classic MRCOG trap regarding twins. Let's break this down. If the first twin is breech, you must recommend a planned cesarean section. That's a solid grade C recommendation. However, let's say the first twin is delivered cephalic and the second twin is subsequently found to be breech. Well, grade B evidence explicitly states that routine cesarean section is not recommended in that case. You can safely proceed with a vaginal delivery for a breech second twin, whether they are at term or preterm, provided that first twin has paved the way. Do not mix these two distinct scenarios up on exam day. First twin breech equals planned section. Second twin breech equals vaginal delivery.
We're going to wrap up with this incredibly powerful summary directly from the guideline. The essential components of planned vaginal breech birth are appropriate case selection, management according to a strict protocol, and the availability of skilled attendants. Adhering to these 3 pillars minimizes morbidity and ensures the absolute safest possible outcome. But as the overall rate of planned cesarean sections just keeps rising globally, we really have to ask ourselves a difficult question. How will the next generation of obstetricians maintain these critical vaginal breech skills to ensure that third pillar never falls? It's something to think about. Keep these evidence grades and clinical rationales front of mind for your exams and, more importantly, for the safety of your patients on the labor ward. Thanks for joining me on this explainer.